So let's talk about coronary artery disease. Here we see a picture of the heart and the coronary arteries. The coronary arteries supplying the heart can become narrowed over time. And we refer to this as coronary artery disease. The narrowed arteries limits the amount of blood supplied to the myocardium, especially during strenuous activity. So there are some risk factors for the development of coronary artery disease. Non-modifiable risk factors are ones that cannot be changed. So for example, with lifestyle modification, we cannot change age. And coronary artery disease has the highest incidence in white, middle-aged men. Another non-modifiable risk factor is gender. And it's important to note that heart disease does kill women 10 times more than breast cancer. Another non-modifiable risk factor is ethnicity. Caucasians have a higher incidence of coronary artery disease. And family history and genetics also play a role. For example, someone can be predisposed to develop coronary artery disease or hypercholesterolemia, which is increased cholesterol in the blood, just due to your family genetics. Modifiable risk factors are those which we can do something about if we make some lifestyle changes. So elevated serum lipids are a risk factor for coronary artery disease, and we can decrease these risk factors by controlling our diet and exercise. Hypertension is another risk factor, and we can treat hypertension with medications. We can also decrease the blood pressure through exercise and diet as well. Tobacco cessation is definitely something that is modifiable. And tobacco is a risk factor for the development of coronary artery disease, smoking cigarettes. Physical inactivity is another risk factor. Having a regular fitness routine will decrease your risk of coronary artery disease. Obesity or being overweight, and diabetes mellitus. So triglycerides or lipids are fats that circulate in the blood, and the risk of coronary artery disease is increased with a fasting triglyceride level of greater than 150 milligrams per deciliter. The risk of coronary artery disease is also increased with serum cholesterol levels greater than 200 milligrams per deciliter. Low-density lipoproteins have affinity for arterial walls. And elevated LDL is associated with increased risk of atherosclerosis. So the risk for coronary artery disease increases with a LDL or low-density lipoprotein level of greater than 130 milligrams per deciliter. So the HDLs are the high-density lipoproteins, and we refer to these as the good lipoproteins or the good cholesterol. These carry lipids away from the arteries to the liver for metabolism. So these help prevent lipid accumulation within the arterial walls. And the desirable levels for HDL are between 37 and 70 for men and 40 to 88 for women. So the higher your HDL level is, the better. So the coronary arteries supplying the heart can become narrowed over time. And the narrowed arteries limit the amount of blood supplied to the myocardium, especially during strenuous activity. Here we see a normal artery, and then we see an artery with atherosclerosis, which are fatty deposits of plaque on the arterial wall. So we can see that the arterial wall in the example with atherosclerosis is narrowed. So we're going to talk a little bit about how these plaques form and exactly what the process is. Okay, so initially there's damage to the endothelium, which is the inside of the arterial wall, and things that damage the inside of the arterial wall include hypertension, tobacco use, hyperlipidemia, which is increased fats in the blood. There's hemodynamic factors involved. Diabetes is another culprit for causing damage to the endothelial layer, infections, and immune reactions. So the endothelium is that inner layer of the arterial wall, and if it becomes damaged, there's this immune response to the injury. So the monocytes, platelets, and macrophages are sequestered to ingest the dead cells and fat accumulation that's present in the intima. So here we see a fatty streak in the endothelium, and once this fatty streak forms, there's a fibrous plaque, and the endothelium is not able to repair itself once the fibrous plaque forms. So these fissures or tears are left in the hard collagen cap that forms. So here's an example of this fibrous plaque which forms, and small tears or fissures are created in the plaque formation. So we can see the lipid pool of fats that have developed, and the fissures, and the fibroblast, and then this collagen cap that kind of encapsulates the whole plaque. So a complicated lesion, in a complicated lesion, platelets actually stimulate protein receptors that attract fibrinogen, and a clot is formed. So here we see an example of a complicated lesion, and we have a thrombus, which even causes more narrowing of the artery. So in this complicated lesion, platelets begin sticking to the wall. The platelets stimulate a receptor that binds fibrinogen, and a thrombus forms. Now, oftentimes, patients will develop collateral circulation. All right, so here we see an example of normal circulation, and then we see there's a blockage on the other side where collateral circulation is. And this collateral circulation will bypass the blocked area, and then the blood flow will be reestablished through angiogenesis, which is the creation of new blood vessels. Here we can see another example picture of collateral circulation, where we can see the blockage in the artery, and then we see the angiogenesis or formation of other arteries to reestablish the blood flow to the heart.